morning all. I would like to welcome all to the College of Sessions of Sri Lanka 49 Sri Lankan Surgical Congress. And we'll be having two parallel sessions today, Hall A and Hall B for the three papers. So I would like to start off by introducing the first two chairpersons of Hall B. That would be Dr. Dhammika Disanayak and Dr. Satish Vijayamana to start off the proceedings.
Okay, good morning, everybody. Now let's start the session on free papers, session 2, room 2. Let me invite Dr. Janaka Pereira, who is going to present a prospective study of patients with necrotizing fasciitis treated at DGH Coronado in 2019. Okay, you can start.
Yes, sir. I'm ready, sir. But I'm having problem with sharing my screen. It's not allowed yet. The host is not allowed to share the screen yet.
Yeah, I muted. So you have to present from your screen then. Dr. Janaka Pereira.
Yeah. Now I can, sir. Yeah.
You can, is it? Share your screen.
Yes, now I can.
Okay, good.
Yes.
Okay, we are starting.
But start the presentation, click the presentation on, yes.
Okay, sure.
Yeah, that's good, thanks.
Okay.
Yeah,
you can go on.
The
timer starts, you have 6 minutes.
Yeah, this is the prospective study we conducted in DGH Coronado 2019. This is regarding necrotizing fasciitis. As we all know, it's a rapidly progressive disease in the soft tissues and the skin mainly. Being a Coronado having abundance of agricultural lands, necrotizing fasciitis was abundant in that place. It was common. In our study, usually necrotizing fasciitis, it is clinical diagnosis, almost all. And the treatment is proper diagnosis and surgical debridement. Irrespective of this care, all around the world, the fertility rate exceeds more than 30%. And there are atypical cases which can present as just cellulitis like soft tissue infection, which will limit the diagnosis and delay in the diagnosis, causing fertility, increase mortality. So far, as for the help for the early diagnosis of these atypical cases, there is a score, laboratory risk indicator, but this score is also not yet prospectively validated. It is basically based on laboratory findings. Two of our studies to correlate these basic laboratory investigation findings, which already mentioned in the previous score, and also the importance of positive plain X-ray findings to formulate a better diagnostic score and also to help for the early diagnosis of these atypical presentations. The methodology we did was this is a prospective study and conducted in the DGH Coronado. We recruited 24 patients. Actually, all those patients, the patients we included in our study was who has underwent surgical debridement for the diagnosis of necrotizing fasciitis. Around 24 patients, 14 patients present as a straightforward diagnosis. We did a surgery within 6 hours like, and there were 10 patients which presented with atypical presentation like just normal cellulitis like infection. So all these patients we did full blood count, CRP, random blood sugar and ABG, and also plain X-ray of that particular affected area, and also bone soap culture before the surgery. So what we observed in our study was out of all those patients, 75 patients are more than 60 years. And diabetes mellitus was an associated factor, more than 2/3 of patients. And mostly all those patients had WBC count more than 15,000. And also 58.3% patients WBC count more than 25,000. 83.3% patients had CRP more than 150, and the main area which we emphasize in our study, that is a plain X-ray findings positive for soft tissue gas. It was 54.1% in our study. And also bone subcultures were polymicrobial. Irrespective of this surgical care, like around 1/3 of patients, death rate was 33.3. The patients who straightforward underwent surgical debridement, and the patients who diagnosed delayed, that is we did surgical debridement after 12 hours, their death rate was 100%. Actually, those are the patients who present with atypical presentations. So, as a summary of our findings, so all these things, age more than 60 and the diabetes, WBC more than 15,000, CRP more than 150, and mainly the soft tissue, presence of soft tissue gas in the X-rays, all are favoring for the diagnosis of necrotizing fasciitis and helps in the early diagnosis of these atypical presentations. In this discussion, in 24 patients, 14 patients present with straightforward diagnosis, but 10 patients, they present with normal soft tissue infection. So, as I already mentioned about my findings, so the conclusion of our studies, this high WBC count and CRP values, those are important in diagnosis in necrotizing fasciitis, already mentioned in the previously score, that is laboratory risk indicator. And also we suggest the presence of soft tissue gas in the plain X-rays and the presence of diabetes as well as advanced age. All these things also we can correlate to form a better score to diagnose these atypical presentations. Thank you, sir.
Okay, now now you have additional time for questions. Did you identify the organisms? You said
Yes,
some of them are polymicrobial.
Polymicrobial, yes.
Yeah. Did you identify the organisms?
Yes, there were like gram positives and the mostly gram-positive organisms there, streptococcus and staphylococcus-like organisms, and also pseudomonas is also there. But more.
What was the gas in the soft tissue X-rays, do you think?
It's in the gas in the superficial fascia, like sir.
Yeah, I know. Now, what could have been the cause? Gas-forming organisms, or?
Yes, gas-forming organisms, sir.
Such as?
There was like gas shadows within the soft tissues.
What were the suspected organisms? Now you did culture all of them, but you saw gas in some X-rays. What could be the reason?
There were like
positive organism.
The anaerobes was there, sir, and like pseudomonas, clostridium was there in some specimens, some samples, and the pseudomonas is also there.
Did you send cultures from tissues in all of these cases?
All of these cases, sir. Yes, all of these cases.
Most all were positive for something, one or more organisms.
Yeah, some samples they said they can't differentiate because they just mentioned about polymicrobial only.
So they didn't identify in some cases.
Yeah, not all, sir.
Yeah. You didn't mention about the antibiotic management in this series.
Yes, sir. We initially started the empirical antibiotics treatment, sir. Then the patients who present with septic shock, we started meropenem-like antibiotics. Then after the available of the culture BST, we changed the antibiotics according to that.
Thank you. Your time is almost over.
Yes, sir.
Thank you.
Thank you, sir.
Right. Okay, thank you. Dr. Dhammika, can we go, Dr. Dhammika Dissanayake, can we go ahead with
Yeah. You have to start the other one.
Okay, so this is Dr. Satish Vijayman, I'm the co-chairing person. I would like to invite Dr. IHDS Prasad to talk on his free paper, Unipedical Neovascular Islanded Pulp Advancement Flaps, a better choice for fingertip reconstruction, a case series.
Yeah.
Can we start?
Yes, I'm sharing the screen.
Yes.
Am I successful? Can you all see my screen?
Yes, we can see.
You have to make it full screen.
Yeah, okay.
For slideshow.
Yes, sir.
Still the other view, the editing view.
Yeah.
You have to get the
Now,
good.
Wait. Shall I start?
Yeah. Start.
Yeah, sure. You can start.
Yeah.
Yeah, the clock is clicking.
Yeah, okay. Right. So, good morning. I'm Dr. Samita Prasad. I'm Senior Registrar Plastic Surgery from National Hospital, Sri Lanka. Here, I'm going to present you my case series on unilateral neurovascular islanded flap as a better choice for fingertip reconstruction. As you all know, fingertip is a sensory organ, very vital sensory organ for all of us, and is a cosmetic unit. Because of that, fingertip reconstruction is always a challenge in hand surgery. Achieving the volume with good quality sensation and good cosmetic nail are realistic goals with this neurovascular islanded pulp advancement flaps. In our study, we have included 11 patients with transverse or volar oblique, that is volar unfavorable traumatic amputations of fingertips with only 30% or less remaining nail, which were not suitable for conventional VY advancement flaps because they are volar oblique or volar unfavorable. After the initial debridement, we preserved bony length as much as possible. Then we planned unilateral, either unilateral or bilateral or total pulp advancement flaps as cup flaps. The method we used is after delineating the anatomy and marking the flap, we started elevating the flap from distally and from laterally. Then we freed the flaps from the Cleveland, dividing the Cleveland's and Grison's ligament and periosteal branches. And finally, the flap was only connecting to the finger with the neurovascular bundle. So it's the so-called islanded flaps. In this technique, we, in actually our total pulp advancement technique, we never made any cuts through the pulp. So because of that, we could preserve most of the cutaneous branches which supply the pulp. Unlike the conventional VY advancement flaps, where you may cut across the pulp as a V shape, so you might damage more cutaneous nerves there. We followed up our patients initially for 4 weeks very closely to see whether they are developing any flap necrosis and flap infections. And then we, in our case series, we have followed them up to 1 year to observe good sensory recovery and a good cosmetic nail outcome. Here in my study, I did 2 kinds of flaps. Firstly, it's a lateral neurovascular islanded flaps or Cutler flaps, which were described by Cutler a few decades ago. And secondly, we in our unit, we developed a unilateral total pulp advancement flap. So this is the first time it is described in the literature. I couldn't find any documented literature in the published papers. So I might call it Colombo flap. So this is the conventional Cutler flaps. this is how we have designed it. And this is intraoperative photos. The flap is only fully mobilized, only connected with the neurovascular pedicle. So my left photo is immediate post-op. The right one is after 2 weeks. You'll see good healing of flaps and good contour. So this is the Colombo flap or total pulp advancement flap. If you see in this left hand, the reconstructed finger is the ring finger. It's because we have preserved the length as much as possible, and scar is barely visible, and shape has contour has regained. So it's barely visible that we have reconstructed that finger. This is the most recent one we did, where we did total pulp advancement flap as a neurovascular islanded flap for 2 fingers. This is the immediate, maybe 3-4 days after the surgery. You can see.
1 minute.
Okay.
You have less than 1 minute.
Yeah, these are previous cases. You can see even the nail here, the left photo and the right photo, the nail is growing. So see this nail bed expansion, auto expansion actually. So we could take a mean advancement of flaps of 12 millimeters. And in 1 patient, we did hypothena graft and 2 patients nail bed grafts. There were 2 partial epidermal losses, but they didn't require any further surgery. So after 8 to 12 weeks duration, patients developed total sensation with good 2-point discrimination also. Nail bed expansion, auto expansion was seen in all patients. And finally, they had 40 to 50% the previous length or the length compared to contralateral finger. Within 1 year, they didn't develop crooked nails. With the pressure and scar therapy, all patients regained excellent cosmetic outcome with good pulp contour, as I shown you in my postoperative photos. So neurovascular island flaps are promising in fingertip reconstruction, but our sample size is smaller still. So we need long-term follow-up and a good, a bigger sample size for better comparison. Thank you.
Thank you, Prasad. I think the paper is open for discussion. Let me ask with the first question, couple of questions I've got. In your series, what like the injury pattern to begin with?
Yeah, they are either crush injuries. So after debridement, we make it a clean surgical wound anyway, or a clean cut wounds, which are not, which are not amenable for replants because they are very distal. At the 30% of the nail, maybe or less than that, they are not amenable for plantation, or they are volar unfavorable. So our routine VY flaps cannot be easily done.
Right. The next question is, now you based it on a single digital vessel, I believe. Yes, that's the discussion.
Yes.
So yeah, the continuity of the other digital vessel, was it there or was it compromised due to a part of trauma? Now sometimes the injury is extensive. Okay, when you raise the so
no,
it's always there wasn't a problem at all.
Yeah, we didn't include extensive crush injuries where there's, I mean, when we actually, we have to, because we are doing an islanded flap, that the location where we take the flap is
time is over, Satish.
Yeah.
Right.
Time is over.
Okay. Right. Thank you, Prasad. Then can we take any more questions, Dr. Dissanayake?
No, finish. Time is over.
Okay, right.
I'll introduce the other one.
Right. Thank you.
It's also by Samita. It's experience of a novel cadaveric model for reconstructive surgery simulation. Phenoxyethanol based cadaver presentation. You can start, Samita.
Okay, sir.
Have you started? Last time you lost some few seconds.
Yeah. All right. Okay. So.
Okay, we are starting the time 6 minutes from now.
Okay.
Bigger screen. Okay.
All right. Here I'm going to present you a study I did with the Faculty of Medical Sciences, University of Sri Jayawardenepura, and their Department of Anatomy, where they are practicing a newer method of cadaver preservation, that is phenoxyethanol based cadaver preservation. So we planned a series of workshops, and hello, can you all hear me?
Yeah.
We,
Fine.
yeah, we
Let's
can,
Hello.
go on.
loud and clear.
Hello.
Yeah.
We
Let's
can
go
hear
on.
you.
We hear.
Yeah. So traditionally, traditionally study anatomy, but tissue changes induced by formalin make it a poor substitute for plastic and reconstructive surgery simulation, because it's mostly microanatomy that we deal with. This new embalming technique with phenoxyethanol helps soft fixation and gives cadavers a lifelike quality. So here, as you all know, these cadavers were donated for teaching and research. This phenoxyethanol is a cocktail of chemicals. They practice the injection of 20 liters of this solution to bodies via femoral artery for 48 hours. And then these cadavers are kept in 0 to -5 degrees for 6 months. We have planned microsurgical flap and nerve reconstruction workshops for consecutive 5 weeks, covering head and neck, trunk, limbs, including brachial plexus. So after the workshop, we took a feedback from consultant plastic surgeons, senior registrars, regarding the tissue quality as a self-administered questionnaire. So these are our results. Surgical simulation of many procedures ranging from skin excisions to microsurgical tissue reconstructions were performed with a special emphasis on microanatomy. And our group consisted of 5 senior surgeons with more than 10 years of experience, 4 junior surgeons with more than 5 years experience, and 7 senior registrars. So these are the responses we took from them through the self-administered questionnaire. So of the participants, 12 out of 14, that is 85.5%, agree that the experience was similar to operating on live patients. In comparison to living patients, skin architecture was 65.7% similar, muscle quality was 80.7%, blood vessel architecture was 80% preserved, and nerve texture and flexibility was 86.5% similar. So these are the conventional formalin preserved cadavers. This is the new method. You can see the muscle texture, skin, subcutaneous vessels were well preserved. This brachioradialis flap we did. You can see the muscle and its finer nerves and vessels very well. Here, this is the ulnar nerve decompression. You can see ulnar nerve, its branches very well, and fat. Here, it shows good preservation of muscles and small perforator blood vessels and the nerves. So in conclusion, it's clear that the utilization of phenoxyethanol preserved cadaver models are a very good method for plastic and reconstructive surgeons. As we are microsurgeons, especially practicing the same procedures in live patients, we can practice it with these cadaver models. Thank you.
Okay, thank you. So you have a lot of time for questions because you finished early. So you have about 3 minutes, 4 minutes.
Okay.
Yeah. So yeah, it's a wonderful technique. So what, based on your present findings, what are your future prospects? How do you plan to make use of this in the clinical practice?
Yes, actually, especially as we all are trainees, before practicing procedures on patients, we should do cadaver models first. That is I think there is a practice in the practice of surgery in developed countries also. The problem we had was the cadavers, when they are formalin preserved, it's unless they are very fresh, it loses its lifelike qualities of those tissues. So it's not. I mean, it might not give you the experience of operating on a live patient. But this new preserved technique of phenoxymethanol, it retains the tissue quality maybe 8 months, 1 year. So we can plan surgical, I mean, before surgery, before doing surgery on patients, we can practice the same procedures on those cadavers. Then we are very confident, and we can get a lot of skills by doing cadaver dissections. Number two is we can do a lot of research. Plastic surgery is a new innovative field, and we always try to introduce new techniques, new flaps. So these kind of cadavers are a very good source for cadaveric research like that, because it's like operating on live patients with a tourniquet on, with a bloodless field. And the other thing is the vessels are well preserved, so the lumen and the fluid inside is still flowing. So you can inject a colored solution, like say maybe red colored dye through those arteries, and then you can delineate your angiosomes or flap territories. And you might even inject radiopaque dye and take them through the image intensifier or II, and take photos and see whether your flaps are well perfused. So like that, research wise also, these cadavers are would be very helpful in the future. And we can invite actually international faculty for our workshops, because they would be very happy to train us on these kind of cadavers. So we are very free to operate, unlike patients. Unlike
Can I ask a question?
Yeah.
Yes, sir.
Prasad?
Yes,
Yeah.
47 minutes.
Now, what is the obvious advantage over doing the fresh cadavers in your paper?
Yes. Fresh cadavers, taking arranging the groundwork is very difficult with fresh cadavers. We have to wait till a cadaver comes, and then we have to, especially these kind of conditions, we have to do some I mean, maybe even COVID test or some other tests on those cadavers before maybe operate on them freshly. And you can't preserve those specimens with the same quality for a long period. These
Thanks,
cadavers,
sir. Your time is up.
yeah.
Your time is up. Thanks.
Right.
Okay.
Thank you. Thank you.
There's a small announcement for everybody now. If there are any questions, you have to use the chat platform and mention the OP number, because the other one is seems to be not working. Okay, thank you, Samita.
Thank you, Samita.
Thank you, sir.
Yeah. Let me invite the next speaker, Dr. Jayanika Seniviratne is going to present his paper on cosmetic outcome of platysma muscle suturing versus no suturing in wound closure after thyroid surgery. It's over to you, Dr. Seniviratne. Are you there?
Yes, I am there.
Okay, right. You can upload your presentation. I'll give you a few seconds. Yeah, it's there.
We are starting timer 6 minutes from now.
Good morning, sir. Good morning to everyone. I'm Jayanik Dilishan, Registrar in General Surgery. I am delighted to be here to tell you about our study of evaluating cosmetic outcome of platysma muscle suturing versus no suturing in wound close of thyroid surgery. Before I start, let me begin to talk about platysma. We all know platysma is a broad sheet of muscle at subcutaneous plane of anterior neck. In thyroidectomy, platysma suturing is a routinely deployed step in wound closure, but it add extra time to the surgery, also make bit trouble in case of reopening post-thyroidectomy hematoma. So we conducted a study to evaluate the relationship between the cosmetic outcome of thyroid scar and Platysma muscle suturing. These are our study settings. It was designed as a randomized double-blinded study with 2 groups of Platysma suture and no suture at Professorial Surgical Unit of Teaching Hospital, Carpal from December 2018 to April 2019. We included the patients of age between 20 to 40 years old who underwent total thyroidectomy for benign thyroid disease. We excluded malignant disease, retroesternal goiters, and post-operative surgical site infections, hematoma, post-operative radiations. These factors we excluded from this study. Patients underwent total thyroidectomy and skin closure done with 5-knot subcuticular polycapron. For group A, we sutured the platysma with interrupted suture of 3-knot polydactyl, put each 2 cm apart. For group B, we left the platysma without suturing. All patients were started the thyroxine from postoperative day 1 for their body weight with dose of 1.6 microgram per kg per day. Turning our attention now to the post-operative follow-up. Duration of follow-up was 6 months. Each patient was seen at first, third, and 6th month post-operatively. At the first month, we assessed them for TSS adjustment and the corrections, to check the drug compliance and to exclude surgical site infections. At the end of the 3rd and 6th month, we again see them for the adjustment of TSH. Throughout the period, THS of all participants were maintained at the normal range, and scar assessment was done at the end of the 6th month. Scar was assessed using patients and observer scar assessment score, POSAS score. POSAS score originally developed by the Dutch Burns Foundation from Netherlands, 1941. There are 12 components, each 6 from patient score and 6 from the observer score. The pain, itchiness, color, stiffness, thickness, regularity are the 6 components of the patient score. And the 6 components of the observer scores are vascularity, pigmentation, thickness, relief, pliability, and surface area. Both observer and patients were blinded in the session of scar assessment. Statistical analysis, we found there were no differences in the POSAS value of cervical scar at the end of 6 months after total thyroidectomy. And that brings me to the end of this presentation. Thank you for everyone for listening.
Okay.
Thank you. Yeah. The paper is now
3 minutes.
open for discussion. Yeah. The question I'd like to ask now, I'll start from the last point what you raised. You picked up the POSA's scar assessment. Is there a particular reason why this was picked up over Vancouver or other scar assessment scales?
So there was no special reason for with our clinical setup, and for our convenience, we used POSAS score. And I obtained much advices from my sirs, senior expertise. They also said with reliability wise also and convenience wise, it is good assessment tool.
Yeah. Now, how do you randomize? How did you randomize in this series? You used a random number generator, or how did you exactly do it?
Actually, sir, it was randomized with the day of the admission. So we having 2 days of admission per week, Tuesday and Fridays. So Tuesday admissions we took for the platysma muscle suturing, and Friday admission we took for the platysma no suturing.
So it's not true randomization, isn't it?
That formula doesn't work. Try saying it another way.
Doesn't matter. Now there's another question from the floor. Was there a difference in complication rate between the groups, like surgical site infection?
Sorry, sir, I didn't get your question.
Between the two groups, now this is a question from the audience. Was there a difference between groups in complication rates, like such as surgical site infection?
No, sir, we haven't seen any kind of a difference between complication between two groups.
Not even hematoma rate, nothing.
No. Only we got a one surgical site infection case and 2 hematoma cases.
In which group?
Infection is get from the platysma muscle suturing group, but hematoma, both 2 cases came from the 2 groups, one from each group.
So do you think the number is adequate to make any conclusions? The number of the groups, is it adequate?
No, I think the number is not adequate in my study because I included 50 patients, 25 for each group.
So how many do you think is a good number to do this study?
With sample calculation, it came as at least 200 patients were required for this
200.
study. Yes.
So are you planning to do that in future?
Yes, still I am trying to develop in this study. Still I am collecting the new data, but it is very difficult to follow up patients for 6 months with our rotation of our appointments because for ideally.
Can I ask a question? Yeah.
Yes.
One of the biggest problem we are seeing the thyroid scar is it's the position of the thyroid scar, whether it's got onto the normal skin crease or like whether it's at the root of the neck. So going back to the surgical technique, was this scar marked preoperatively on seated or standing posture, or this was marked on the bed?
Yeah, sometimes
Okay. Quickly, if you tell, was it marked pre-op or not?
We mark preoperatively, sir, but we try to get through the skin scars,
Okay,
skin pieces as much as possible.
Okay, thank you.
Thank you, sir.
Thank you.
Let's get on to the next one. Is also by Dr. Samita Prasad. Experience in perforator-based propeller flaps in normally reconstruction. Samita, are you there?
Yes, sir. Yes, I'm here. I'm sharing the screen.
Yeah. Just wait to upload.
Okay.
Yeah, we got the picture.
We are starting
Okay,
6 minutes from now.
This study was lower limb reconstruction needs a wide variety of options to choose from. Because of that, perforator-based propeller flaps play a vital role. When other options are not available or suitable, especially mainly in lower 1/3 of the leg. Here, I have included 3 patients that were done during last year. We performed 3 cases in whom the other options like free tissue transfer or any other local flaps were not possible because of either patient comorbidities or extensive injury zone. Here, the propeller flaps were based on posterior tibial or peroneal artery perforators in the lower leg, and perforators were preoperatively identified by handheld Doppler and surface marked. After thorough debridement of the wound, an exploratory incision was made 1 inch away the marked perforator, and through the exploratory incision, we identified the size and quality of the perforators available after perivascular and fascial release. Then the skin flaps were designed isolated on the dominant perforator, and after the flap was fully raised, it was rotated 180 degrees or less before insertion. The resultant secondary defect was skin grafted. These are my photos during surgery. This patient had a lower tibia fibula fracture, EF done by orthopedic team, and the bone and the malleolus was exposed. I have marked the perforator, the lower tibial perforator, and the flap. So this is the flap I raised. You can see a good perforator and a small perforator. This good perforator is sufficient to supply the full flap, so we ligated the small one. This is immediately after insertion. You can see the well perfused, the flap is 180 degrees rotated, and well perfused flap. The color is similar to the surrounding tissues, and the secondary defect was skin grafted, and part of the wound is also grafted. This is after 1 week. The graft was well taken, and the flap remains good and viable. So our results, all of those patients were 40 to 50 years old male patients with lower tibia and ankle exposed wounds. 2 of them are active smokers without signs of established vascular disease. One had controlled diabetes. 2 were acute trauma patients, and the other had chronic osteomyelitis. So the final results, all flaps were successful with good healing. 1 flap had a venous congestion but managed well with negative pressure wound therapy for 1 week and got away with only patchy epidermal necrosis. None of the patients needed repeat surgeries and could hand over to orthopedic team within 4 weeks. So this is the patient whom had the venous congestion. So we immediately after noticing the congestion, we removed the sutures and put a negative pressure wound therapy. And
The
after
mic is
1
not very
month,
good.
our flap is well healed.
Samita.
Yeah, in conclusion, perforator-based propeller flaps are a good and reliable alternative in lower limb reconstructions. Here in our unit, we most of the time we do free tissue transfers. Because of that, I could include only 3 patients for last 1 year. And this is we do a lot of perforator flaps, but this technique is a propeller technique. Where we completely freed the flap and rotate it like a propeller. It's a good technique. This is only 3 cases I have done. I think we can do a lot of cases to do more wider research. Thank you.
Okay, thank you, Samita. Now we have 2 minutes for questions. So far, I have let me make an announcement. I will give additional time for that. Now, previously I mentioned that you have to ask questions on chat platform, but it's not so, it seems. You have to use Q&A. Anybody in the audience? Q&A and send questions using the OP number. Mentioning the OP number. Okay, you agree that the patient numbers in this study is not adequate, isn't it?
Yes.
Yes, so
it's not
maybe
adequate,
if you
it's
do a
good,
bigger study
informativity.
to
Yes.
get more uniform results.
Yes.
Yeah, there's a question. Hold on.
Yeah.
From the floor.
Meantime, can I ask a question, Dr. Disana?
Yeah.
One moment. We are testing this platform. That's why. It says when there are 2 dominant perforators, how would you manage? Now you mentioned one was small, one was big. If there are 2 equally dominant and good perforators.
Yes. Firstly, I would do a perivascular and fascial dissection, and I will see the continuity of the perforator as a very good perforator, and by releasing by getting a prevascular release, I might add another 1.5 centimeter length, so I can do a rotation without twisting the vessels. So then next I would see the distal, which perforator would feed the most distal part of the flap. So I will take the perforator which is closer to the distal part of the flap. And the other factor is when we are rotating, the flap should come and cover the business area. That is the area that we should cover in the wound. So if the perforator is too proximal, sometimes I might not be able to get
Thanks, Amit. Your time is up. Thanks.
Yeah.
Thank you, Prasad. Okay. Thank you, Prasad. Let me invite the next speaker, Dr. G.K. Rajapaksha. He's going to present his free paper on endoscopic carpal tunnel decompression, ECTD, a novel technique in Sri Lanka. Over to you, Kavinder.
Hi, morning. Can you hear me, Satish?
Yeah, it's loud and clear.
Right. I'm going to talk about endoscopic carpal tunnel decompression, a novel technique in Sri Lanka. So I'm the plastic surgeon at Army Hospital, Colombo. So carpal tunnel syndrome, as you know, is the most common compressive neuropathy in the upper limb, and usually this is treated by division of the transverse carpal ligament surgically. This minimal invasive endoscopic carpal tunnel decompression actually was introduced to the world about 20 years ago. And but now it's a novel technique in our country, and currently gaining popularity due to its minimal post-operative pain, as well as less scar tenderness and early return to normal function. It is currently, unfortunately, only available at the Army Hospital, Colombo, and I'm reporting today the first 20 cases we have done. So these are the instruments which we use. We use a 3.5 millimeter 30-degree video scope with the supportive instruments, which can be connected to conventional endoscopic tower, as you can see. And this is also done under local anesthesia using a tourniquet. And this does not involve any palm incision. That is a remarkable thing. It involves a proximal 4 millimeter stab, just proximal to the proximal skin wrist crease, and middle of the palm stab. And there is no saline insufflation, no gas insufflation like in the conventional techniques of endoscopy. But we use a round sleeve to visualize with a 3.5 millimeter video scope. And it is unique in this technique where we visualize the carpal tunnel from inside, and it is a reverse order of anatomy, and the transverse carpal ligament is seen as the ceiling of our room from below. And it only divides the transverse carpal ligament, whereas in the other technique where we have to divide skin, palm, aponeurosis, thinner muscles, and as a result, a very dreadful complication, long-term complication can result. No. So therefore, in this technique, that pillar pain is not seen. So these are the pictures which during the procedure. So as you can see, there's 2 stab incisions where the scope is passed with the trocar, and once the trocar is removed, we have 2 access points. One side we can use for the video scope, and the other side we can use for the instruments, or alternatively. I'm just showing some videos now. This shows the division of the carpal ligament. This is on the top. Now I am using my right hand to divide the carpal ligament, and the left hand to maneuver the camera. And as you can see, there's a special knife, a hook-like knife, which can divide it separately. So this will only involve division of the carpal ligament. And then we go again and see whether there are any remnant bands seen. As you can see on the second video, there's a small band there we found, and that was divided as well. So the first 20 patients who underwent this procedure was taken since the introduction in September 2019. And we assessed pain and numbness on the first week and on the 6th week. So as you know, this study was done in the Army Hospital, so there is a gender bias, so 16 males and 4 females in our cohort. And all patients were operated by the same, I have operated all patients, and all patients underwent preoperative nerve conduction study, and the symptoms were assessed using the Boston Carpal Tunnel Syndrome questionnaire, standard questionnaire. And the assessment was at preoperative, postoperative 1 week, and at 6 weeks postoperative. So with regard to pain severity, initially almost 12 patients had moderate to severe pain and only 2 didn't have pain. And at the end of 1 week postoperative, none of them had moderate to severe pain, only about 12 had mild pain. And at the end of 6 weeks, only 3 had mild pain, all the others were asymptomatic with regard to pain severity. This is a diagrammatic representation of that. And as you can see, 85% was not having any scar tenderness or pain. With regard to numbness, about 18 to patient had mild and 2 had moderate numbness. And at the end of 1 week post-op, only 5 had numbness and 1 had moderate, 14 were asymptomatic. And at the end of 6 weeks, almost all patients except 2 didn't have any numbness. And this is a diagrammatic representation. So average time taken to get back to normal work was 3 days. And this is a preliminary study, so long-term follow-up study with a bigger sample size is required. And as well as we are currently comparing this with the conventional open technique. And in conclusion, endoscopic carpal tunnel decompression release is a better technique when compared to the conventional open technique for the following reasons. That is, first, less post-operative pain and early recovery to normal work. But long-term follow-up studies are needed, and especially to assess the degree of pillar pain, which can experience post-operatively in the open technique as a long-term complication. Thank you.
Thank you. This is not a question, this is a comment. This is not actually a novel technique in Sri Lanka. This was started by me about 10 years ago at NHSL.
Yes, sir.
So it's actually not the two-port technique, single port.
No, that was a different system, sir. That was a square port, single port.
Single port.
Technique is a novel technique because it's a 3.5 meter round sleeve technique. This was not started before in Sri Lanka.
Yeah, I know. Yeah, but ECTRL was started about 10 years ago. That's what I was.
That's right. I was a trainee with you, sir, then.
So there is going to be a big question. Okay, it's from the floor. Are the knives reusable and how expensive are they?
Usually, sir, they don't recommend it's a disposable knife, but at this moment we are reusing it with proper sterilization for about 20 patients. And
sharpness?
Knife, sorry, sir?
Sharpness?
Sharpness, we have managed 20 patients with one knife. And of course,
so is it that expensive? Is it that expensive?
19,000 a knife, I think. So if you can use it for about 20 patients, the cost will be less than 1,000 for a patient. But this was done in the government sector, Army Hospital, so that was free.
Yeah, Kavinder, yeah, it's a nice presentation. It's interesting. I mean, it should get it popular in the country. My question is now, the pain, what you analyze, can you be more specific with regard to the pain? Was it over the suture line, or that's something aching type of pain? No,
actually,
it was, palm.
If you recall the Boston questionnaire, Satish, there are about 11 history points and 9 pain points. So there are some which we analyze as direct tenderness, and the other ones from day-to-day activity, holding a cup and gripping, twisting, all that activity, whether that gives rise to pain. So it's both actually, local tenderness.
Probably so that pain is, probably that pain was not appreciated pre-operatively.
No,
same question. Would have had that pain.
It is the same questionnaire. All 3 occasions, it's the same questionnaire which was given.
So there are two more questions. Even though the time is up, we'll allow short answers. Are there any special indications or contraindications in patient selection over the open procedure?
Commonest contraindication would be, sir, there are complications like a fracture involved or recurrent or repeated surgeries. It's not a relative, it's a relative contraindication basically. But indication-wise, I would suggest it's indicated for anybody because it gives you back to normal within 3 days. I mean, for example, our sergeant major in our army ride their motorcycle next day after the operation. So that gives the good perception of the pain. They don't have any pain post-op.
Okay, then time is up. Thanks, Kavinder.
Thank you.
So we have to go to the last presentation of the session. This is OP33, knowledge and awareness on cadaveric skin harvest among ICU staff members in National Hospital of Sri Lanka. Presenter is Dr. Sivasugandhan Kanesu.
Okay,
Are you
sir,
ready
good
to
morning.
start, Siva?
Yes, sir. Yes, sir.
Okay, we have started the countdown, 6 minutes. You can
Okay.
go.
Okay. Yeah. Yeah. So I'm Sivasugandhan, senior registrar in plastic surgery in NHS. So my topic is on knowledge and awareness among on ICU staff, cadaver skin harvest among ICU staffs in National Hospital of Sri Lanka. You might wonder why I have selected this study. Because now when we get a severe burn patient to our hospital, now early excision and wound cover is a must to reduce the morbidity and mortality. So in other countries, they have skin cultures and artificial skins all available. But in our country, the cost-effective one is the skin bagging and the cadaver skin graft. But in our hospital, we don't get enough referrals from the ICUs to get the skin harvest. So that's why I just want to find out what is the reason behind it, why we are not getting enough referrals from the ICUs. So the skin coverage is the greatest challenge in severe burns when the donor site is limited. And early skin cover after excision is important. So there are different wound covers available. One is skin grafting, autologous or allograft, and dermal analogs, Integra BTM. It was available for a short period, but nowadays it's not available in our country. And keratinocyte coverage such as skin cultures and the membrane. So the cadaver skin allograft act as a temporary biological coverage for the burn wounds. So this is how we take the graft. We clean the body with the povidone iodine and 10% povidone iodine. Then we, by using the dermatome, we take the graft mainly from the thighs. It roughly take 30 to 40 minutes, and they cover the body.
We can't hear you.
Awareness, not the knowledge. So they concluded that like 60% were aware about skin banking and only 20% willing to donate. So they haven't assessed the knowledge on skin harvest. So to assess the awareness and knowledge on cadaver skin donation, I did this study. So it's basically a descriptive study, mainly done in the recovery, neurosurgical, and accident emergency ICUs in NHS, mainly from the doctors and the nurses. More nurses were included in this study. Sample size was 140, and it's a systematic sampling. The analyzed with the SPSS 20 package. The results were 84% were nurses and 16% were doctors, and 60% of the staff were not aware that there's a skin donation is possible from the cadavers, fresh cadaver after death. And 67% complete the diploma because most of them are nurses, and only few are MBBS and the MD doctors, because that is the proportion I could get from the ICUs. So the questions, that's how we have answered. The after the death, within how many hours skin can be donated? So more than roughly one third, they were not aware about what is the time duration, and one third they said immediately you have to take it out. Only 3% has answered roughly 3% correctly. So that's and also the duration of the procedure. Most of them, they are not aware of how long it will take roughly, because that is important to tell the relations, how long it will take the procedures. So only 10% was aware that is only take to 30 to 40 minutes. And who is the donor, who is a possible donor? So roughly one third, they were not aware, and 40% they said there should be blood matching, and 20 to 25% they said HLA matching. Only 30% they said that anybody's skin can be grafted as a cadaveric skin. And other question that we have asked, what are the conditions? Patient with what are the conditions can be donated. So only so the most of them said hypertension, the diabetes can be grafted, can be given graft, and some people have answered the liver disease and heart disease and renal failure. Usually we don't take those patients. And how long the graft remains, most of them they are not aware. So only few patients, only few staff knew that only the 4 weeks the graft remains. And the donor side, they have agreed that most of them we are taking from the thigh. So we find there is a knowledge deficit in the ICU staff. That's probably the reason we are not getting enough referrals. But I couldn't compare this between the doctors and the nurses because the numbers were different. And in future, I would like to assess this in the public as well because they are the main donors. And we have prepared the leaflet to distribute in the ICU. This is we have prepared in the National Burn Center, and we are about to distribute to the ICUs about ICUs to improve the awareness. I think we are planned even in the college session, me and Gayan sir plan to distribute here even in the college. If it's physically present, we couldn't unable to proceed this. Yeah, that's all. Thank you.
Okay, congratulations, you are for a very useful and interesting, very nice study.
Yeah,
you need more work from this field, I think.
Yes, sir. Yes, sir. We actually plan to improve, do awareness campaign in the college if it's going to be a physical session. Me and Gayan sir plan, but we couldn't do this time. We want to improve the awareness.
Why don't you ask more questions? Anybody in the audience, the participants? We are not getting any questions here. No, wait.
Initially, I thought so, but
quickly someone can ask some few questions because
because there's time, enough time, no hurry. This is the last presentation, so we have more time.
Yeah, I also happy to ask.
Yeah. Satish, you don't have any questions? You are a skin man.
That was an excellent presentation, which we have been trying to establish here in Gaul as well. Yes, I think your presentation, the areas what you have touched is a great eye-opener for all the clinicians in the health sector to make it more aware. And I think what we like to see at the next level is the results. So I hope you will continue your same study and like to see work with the results so that which will really where we can pass the message to the society.
Yes, sir. That's the important thing. So I want to
technique wise, did you use a battery operated dermatome or was it a power electric or an air compressed dermatome?
So it's a battery operated one.
What was the width you achieved? The maximum width of the graft with your battery operated dermatome?
So the problem is, NHSL, the battery operated one, we couldn't use properly because we have used, the battery was not properly working. So we partially started doing, and also we combined with the our dermatome.
Manual dermatome.
Manual dermatome, yeah.
Right.
Manual
dermatome. Right.
Yeah,
right.
It's a combined one.
There are more questions. One is a suggestion. There's a suggestion to do an audit cycle after awareness program.
Definitely. I'm going to do it.
Then what are the cadaver categories? What are the cadaver categories? Do you have any answer? Or shall I go to the next question? Next question is, can you harvest from patients suspected of sepsis, died of sepsis?
Yeah, we can't. Sepsis, AIDS, hepatitis, and septicemia, those patients we can't.
Any answer for this other question? What are the cadaver categories? Do you get the question?
There is nothing like that, sir. Any cadavers we can utilize for the skin harvest. There are some few contraindications like septicemias, and skin quality is very important. Like patients with liver disease with high bilirubin, we are not taking, and kidney disease with poor skin quality, we are not taking. And any
So from a patient who has had a extensive burn injury in the past, you're not taking
definitely can't. The skin quality is important. Yeah, that's the only issue. Other than that, there's no other issues.
And no, this is actually not part of the presentation. Now, how would you compare these allografts to xenografts? Is there any point doing a say pig skin or something?
I haven't thought about it, sir.
I'm asking because there's
I know. Yeah, there's a fish and the pig. Yeah, people are used, but I don't think at the moment anybody using, sir. At the moment,
well, I think very few indications, but I'm wondering, these are temporary things, so why not? So, what do you know about it now? How do you compare the survival time between allograft and xenograft?
Actually, sir, I'm not.
Time is up, I think. Thanks.
Yeah, actually.
Excellent.
Okay, sir. Thank you.
Thank you. Thank you for all the speakers. Thank you.
Good morning and welcome to the second of today's sessions. We are running two parallel panels at the moment. It's Hall A and Hall B. This is Hall B. Let me introduce our chairpersons for today's session, Dr. Sanjeev Seneviratne and Dr. Stravinsky Pereira. Up to you, sir. Let's start the session.
Okay, good morning everyone. We welcome all the presenters for this session. Please prepare for session number 4. And just to brief you on the instructions, you will be given 6 minutes for your presentation, and then there will be 2 minutes for your 2 minutes for questioning and discussion. So please ensure that you finish your presentation within 6 minutes. And if you fail to do that, we will have to unfortunately disconnect you and get on with the questions. Right. So first we will start off with the first presenter, OP2, the safety and feasibility of intrathecal stem cell therapy for spinal cord injuries, a retrospective study to be presented by Dr. Mahesh Kamkanamge. It's over to you, Mahesh. If there's any issue, can we get on with the second presentation? Okay, so the second presentation would be by Dr. A.H.M.A.H. Abhay Singh on comparison of laparoscopic entry techniques, experience from a general surgical department of a tertiary care center. It's over to you, Dr. Abhay Singh.
Good morning, everyone. So I'm going to discuss about the various laparoscopic entry technique. It's a comparison of laparoscopic entry technique, which is a study was done in General Surgical Department, National Hospital, Kandy. Sorry for that. So to begin with, it's a comparison of laparoscopic entry technique. So in laparoscopy, most important thing is to achieve the adequate space to operate. So this space is created by either by mechanical retraction of the abdominal wall or by the gas insufflation to achieve the pneumoperitoneum. The commonly used method is the carbon dioxide pneumoperitoneum. The gasless laparoscopy or the mechanical retraction of abdominal wall technique is not widely used. So to proceed with laparoscopic surgery, the most important thing is the initial access or the abdominal entry. This is a challenging procedure because of its associated with serious complications such as major vascular injury and the bowel and the visceral injury. Though these injuries were very rare, but we have to keep in mind these injuries were life-threatening. In literature, it says at least 50% of these major complications occur prior to the commencement of the intended surgery. As well, they say most injuries are caused by the insertion of the primary trocar. There are several techniques which we can use for the entry technique. The commonly used technique were the open Nasson technique, the closed varus needle technique, direct trocar technique, and the optical access technique. So I'm going to discuss each and every technique very briefly. The open technique, after anesthetize the patient, we insert inside the skin at the level of umbilicus and we deepen up to the linea alba, then enter into the peritoneal cavity under direct vision. Then the primary cannula with the blunt trocar inserted, and after confirming the position by telescope, insufflate. In this technique, we enter into the peritoneal cavity under direct vision. Whereas in the closed varus needle technique, the varus needle, as you all know, it's a spin-loaded needle, which we use to pierce the layers of the abdominal wall to enter into the peritoneal cavity after confirming the correct place by several methods, the double click for the saline drop test, and we can achieve the pneumoperitoneum and place the primary port. In this technique, comparing with the open technique, we enter into the peritoneal cavity blindly. So the direct trocar technique, as shown in the picture, we raise the anterior abdominal wall by using 2 towel clips of hand to stretch the peritoneum, and using 5 mm sharp trocar, we inserted directly into the abdomen, directly. Using 5 mm sharp trocar, once the resistance of stretched peritoneum has overcome, we keep the cannula and remove the trocar and confirm the position by 5 mm camera, and then proceed with the gas insufflation. This technique is widely used for the where the lateral entry is required, lateral ports are required, like in laparoscopic colorectal surgeries. The other technique is optical access technique. So in this technique, initially we have to have a pneumoperitoneum. Then by using varus needle technique, then we inside the skin. Then we introduce the trocar with the 0-degree scope while within the layers of the abdominal wall until we see the peritoneal cavity. So to select each and every technique, so we have to consider few factors. We have to decide what is the organ that we are going to operate. And also, if the patient is having scarred abdomen, we might have to think about the additions and might change our entry technique. And also the available facilities. Some centers might not available the optical access technique. And the most important thing is the surgeon's preference and the experience. An appropriate technique and the location of ports plays an important role in the laparoscopic surgery to progression as well as the ergonomic experience of the surgical team. So in our study, we collected all the patients who underwent laparoscopic surgery in general surgical department in National Hospital Kandy over a 1-year period, starting from 2019 April to 2020. We collected the basic demographic data and the type of laparoscopic surgery and the entry technique and the immediate complication related to the entry technique. What we found was there were 228 patients in our sample, 53% were female, and mean age of our sample was 44.1. Most of the patients, 69.2, had undergone elective laparoscopic surgery, while 70 patients underwent urgent laparoscopic procedure. Among the elective laparoscopic surgery, the common laparoscopic procedure was laparoscopic cholecystectomy, followed by laparoscopic hernia surgery, then the laparoscopic colorectal surgeries, and the upper GI surgeries. So concerning about the abdominal technique, most of the surgeon and most of the time they use the open Nesson technique to get the initial access, 90% as a percentage, 90%, and 9% by direct trocar technique, and 1% by the varus needle technique. And all the direct trocar technique entries were for the laterally placed ports in a patient with a virgin abdomen in our sample. Interestingly, no major complication related to the entry technique that hindered the progression was recorded in all 3 groups. So we concluded that using our data, the open technique was favored, while direct trocar technique has shown to be safe as well as a feasible technique, especially when we are considering the laterally placed ports are required in a virgin abdomen. Thank you very much, and I would like to acknowledge the patients who participate in this study and my teachers.
Now the paper is open for discussion. Are there any questions from the floor? Can I ask them, so how many surgeons were involved in this study?
In our hospital, there were 3 general surgical departments. So each unit, 3 consultants with 2 residential surgeons. The others are SAARC.
Didn't you kind of think of including the VOGs, because they are the people who would be using more varus technique to gain entry, so you would have been able to do a better comparison of the 2 techniques, because here vast majority are open Nesson techniques.
That's why the sample, the varus needle technique is very low, because 1% of.
So probably in the future you can do a comparison with including them, so that you will be able to do a more useful comparison between the 2 techniques. Okay. Right. Anyway, thank you very much for your presentation. Thank you, Dr. Abhay Singha.
Thank you.
Yes, and the next presenter will be Dr. R.N. Samarasinghe. We will be speaking on the clinical accuracy of Alvarado score in the diagnosis of acute appendicitis in Sri Lankan patients. Over to you, Dr. Samarasinghe.
Okay, good morning, sir. I am Dr. R.N. Samarasinghe, Registrar in Surgery. Clinical accuracy of Alvarado score in diagnosis of acute appendicitis in Sri Lanka. This was conducted at Sri Jawaharlal General Hospital. Acute appendicitis is the most common.
Dr. Samarasinghe, we can't hear you.
Can you speak a little louder, please?
Hello?
Yeah, that's better. Thank you.
Okay. Acute appendicitis is the most common cause of acute abdomen. Its incidence is 1.5 to 1.9 per thousand in male and female population respectively. The condition is difficult to diagnose, especially during the early stages when the classical signs and symptoms are usually subtle. Different disease
Can you
processes
pin
mimic the
yourself
diagnosis
onto
of
the
acute.
presentation? Sorry to disturb you. Can you pin yourself so that others can see your face while you do the presentation?
Okay.
Click the presentation, please, and pin it.
I take the presentation, sir.
Yeah, now it's okay. Thanks. You can continue. Thanks.
Okay.
Yeah, you can continue, Dr. Samarasinghe.
Okay, sir. Acute appendicitis, the different disease process mimic the diagnosis of acute appendicitis, as there are a number of causes leading to the pain in the right iliac fossa, particularly in the female patients. The classical signs and symptoms of acute appendicitis were first reported by Feats in 1886. Since then, it has remained the most common diagnosis for hospital admission, which requires laparotomy. Approximately 6% of the population will suffer from acute appendicitis during their lifetime. Delay in diagnosis may increase the morbidity and cost. Attempts to increase the diagnostic accuracy in acute appendicitis have included imaging by ultrasonography, computed diagnosis, laparoscopy, and even radioactive isotope imaging. Various scoring systems have been devised to aid diagnosis process. Alvarado score. Alvarado in 1986 put forward a scoring system for diagnosing acute appendicitis. This original research was a retrospective study of 305 patients who were hospitalized with abdominal pain suggestive of acute appendicitis. The scoring system as described by Alvarado is based on 3 symptoms, 3 signs, and 2 laboratory findings. It is also called the Mantel score based on the mnemonic, migration to right iliac fossa, anorexia.
Again, sorry to interrupt. Still, your presentation is not seen on the app. Can you pin it, please? We can see, but the others can't see it. Yeah, they can see only you, but not the presentation. Can you double click the presentation and pin it?
Now, sir. Is it settled now, sir? I can't see.
Yeah, don't worry, we will give you additional time at the end because one person is not here today.
Okay, sir. So, can others see the presentation at the moment, sir?
Right, continue.
Yes, Alvarado score in a simplified form. As you can see, there are 3 symptoms, 3 signs, and 2 laboratory findings. Right iliac fossa tenderness will give 2 marks, and leukocytosis will give 2 marks. Others will get 1 mark each. And scores more than 7 will consider as a possibility of acute appendicitis, and surgical management is recommended. In our study, this was conducted to assess the clinical accuracy of Alvarado score in the diagnosis of acute appendicitis in a cohort of Sri Lankan patients to fulfill the lacking data on appendicitis management in relation to the Alvarado score. This was a retrospective analytical study. This was performed in patients admitted with right lower abdominal pain, and data were analyzed from 2018 to 2019. Alvarado score was calculated based on the initial in-node assessment, and surgical decision to operate or to consider to manage was taken irrespective of the score, and the data regarding the outcome and histological reports were recorded. The clinical outcomes and histology were correlated with the Alvarado score, and the statistical analysis was done using the chi-square test, and the sensitivity and specificity was calculated. So these are the result. We had a population of 107 patients. As you can see, 61.7 were male and 38.3 were female. So we had a male predominance. And these are our result. As you can see, we got the cutoff mark of 7 as our study cutoff mark. And we calculated in the same go CRP value, ultrasonic findings of these patients, and histological outcome. Out of them, for 3 patients, we have to go for a CT in diagnosis because they were obese patient with a BMI more than 30. So these were our result. The mean age was 34 years with a standard deviation of 18 years. 61.7 were males and 38.3 were female. 25% underwent appendicectomy. The overall sensitivity and specificity were 71% and 94% respectively. In the males, the Alvarado score was 78% sensitive and 98% specific. However, in females, the sensitivity and specificity were lower, 64% and 88% respectively. Eldorado score correlated well with the clinical outcome with the p-value less than 0.001. At the same time, other analytical outcomes, ultrasound scan was suggestive of appendicitis with a sensitivity of 100% and specificity of 87.5 in this study. And ultrasound scan correlates with the Eldorado score, but the CRP value does not correlate with the appendicitis with a sensitivity of 57% and specificity of 58.2%. In conclusion, the Eldorado score had an acceptable clinical accuracy in this cohort of Sri Lankan patient. However, in females, the accuracy was lower than in males. Therefore, Eldorado score can be used as a clinical guide in decision making in the management of acute appendicitis. Ultrasound is a sensitive device, but which is a user-dependent investigation. CRP values did not appear to be a sensitive marker in this study. These are my references, and I'd like to thank you all for conducting this event in the virtual form.
Thank you, Dr. Samarasinghe. Now the paper is open for discussions. Are there any questions? Dr. Samarasinghe, I have a question. Now you mentioned ultrasound had a nearly 100% sensitivity. So out of your cohort, what percentage of people had an ultrasound scan done? I might have missed it. All the patients had an ultrasound scan done and picked up in 100% of the patients?
Yes.
Okay, that's quite strange because that is quite different from what is described in the literature. And I'm quite surprised to see the CRP values, because just over 50% only had an elevated CRP value.
Yes.
What does the literature say about CRP in appendicitis?
There are many different literatures. In some studies, they have taken as it is a sensitive marker, but in some studies, they have taken it as not so sensitive. In
So
this
what is the
study,
you took for CRP values?
We took some more than 20 in our biological assessments.
Is it the normal cutoff, or is it is that the normal range 20 up to 20 is normal in the hospital?
Yes, hospital range bit varies. We took it as more than 20 as the values.
Yeah, because if the upper limit is 6, then taking 20 may not be the standard way of looking at it, no?
Yes.
Okay. Are there any questions from the audience? Yeah, in the absence of any further questions, thank you, Dr. Abhay Singhe. We will move into the next presentation, OP number 26, Correlation of Thyroid Cytology with Histopathology, a single unit experience, to be presented by Dr. E.M.M. Ekanayake. Over to you, Dr. Ekanayake.
Okay, sir, thank you. Can you see my presentation,
yes,
sir?
I can see the slide. Thank you.
Welcome everyone, chairperson, sirs, and the audience. I am going to discuss my pre-paper, that is Correlation of Thyroid Cytology with Histopathology, a single unit experience. Regarding background and the introduction of fine needle aspiration, the fine needle aspiration for cytology is considered as the gold standard of the tissue diagnosis of thyroid disease. It is cost-effective, readily repeatable, and minimally invasive procedure with minimal complications. It is widely used in the identification and further planning of management of malignant and benign condition of the thyroid. It also has excellent patient compliance as well. But FNAC has a varying sensitivity and specificity in different institutions. So our aim was to determine the correlation of thyroid cytology with histopathology in our institution. Regarding our methodology, this is a retrospective comparative study of 305 patients from January 2002 to December 2019 who were clinically and biochemically euthyroid and underwent thyroidectomies at University Surgical Unit, Colombo North Teaching Hospital. And we compare the data of fine needle aspiration cytology and their histopathological findings using SPSS. Cytological findings were categorized as benign neoplastic malignant lesion. And the correlation of histopathological finding was performed with the FNAC. We calculated the sensitivity, specificity, and the positive predictive values and the negative predictive values in our sample. So these are our results. The total sample size was 305, the studied sample, and mean age of that the sample was 46 years. ranging from 15 years to 80 years, and 86.4, that is 264 patients was female. And the most common fine needle aspiration finding was colloid goiter, that is 216, 17.8%. And the among them 52, and the total sample, the 52 was malignant lesions. Most common malignancy we detected was papillary CA, that is 37 on cytology. Among the 216 cytologically diagnosed colloid goiters, only 3 patients came as papillary CA in histopathological analysis, that is 1.38. And you can appreciate the comparison of fine needle cytology with their histopathological diagnosis in neoplastic lesions here. Among 89 total neoplastic lesions we diagnosed by cytology, the follicular neoplasm count was 46, papillary carcinoma was 37, Hürthle cell neoplasm was 4, and the medullary carcinoma was 2. Among the 37 cytologically diagnosed papillary CAs, only 30% was presented as papillary carcinoma on histopathology. And we diagnosed 2 medullary carcinomas on cytology. All those 2 medullary carcinoma was confirmed in histopathology as well. So we calculated our sensitivity patterns, sensitivity and specificities. Sensitivity was 95.8 and the specificity was 91.3. Then the positive predictive value was 77.3 and negative predictive value was 98.6. So our data was comparable with our other published data in the literature, in which sensitivity ranging from 65 to 98%, the specificity ranging from the 72 to 100%, positive predictive values ranging from the 34 to 100%, and the negative predictive values ranging from 83 to 100%. So in conclusion, our fine needle aspiration cytologies has a high sensitivity and specificity which is comparable with the existing figures of the literature. I would like to thank my patients and the teachers as well. Thank you, sir. That's all.
Okay. Thank you very much, Dr. Ekanayaka. Are there any questions from the audience? Yeah, I have a couple of questions from you, Dr. Ekanayaka. First, now this was a retrospective study. Were you able to find out whether the FNAC was done from the same nodule which was assessed histologically? For example, in your colloid nodules, you mentioned certain percentage of people had false negatives, that they were histologically proven as papillary carcinomas at the end. Was it the same nodule or was it a different nodule?
Sir, because of this is a retrospective study, we couldn't. That is a limitation of this study. We couldn't the histopathologies regarding the total thyroid sample, not for the specific thyroid nodules.
Yeah, because we know anyway about 10% of the thyroids they have the incidental papillary carcinoma, so that may not be an accurate statement. Therefore, second thing is, now in your analysis you mentioned fine needle aspiration papillary carcinoma, but sometimes we get not as papillary carcinoma, it's Thigh-5 or Thigh-4 or otherwise Bethesda 5 or Bethesda 6. So did you look at it like that, or how did you confirm the FNAC papillary carcinoma? What did you take as FNAC papillary carcinoma? Whether it's only Thigh-5 or Thigh-4?
Sir, both Thigh-4 and Thigh-5 lesions, sir.
Did you look at them separately? Because Thigh-4 anyway we know the sensitivity is only about 75 to 80% maximum, whereas Thigh-5 it has nearly 98 to 99%. If you go to Bethesda 6, it's 100%. So did you look at it like that separately?
No, sir. This is total Thigh-4 and Thigh-5 lesions. The Thigh-6.
Right. Any more questions from the audience? Yeah. In the absence of further questions, thank you very much, Dr. Ekanayaka.
Thank you, sir.
We'll move on to the next presentation.
The next presenter will be Dr. R. Jayasinghe. He will be speaking on long-term post-treatment quality of life in breast cancer patients who underwent mastectomy versus breast conserving surgery, experience of a tertiary care surgical unit. Over to you, Dr. Jason.
Good morning. Firstly, I would like to thank the College of Surgeons for giving me this opportunity to present. So today, I'll be talking to you on long-term post-treatment quality of life in breast cancer patients. Breast cancer is the commonest diagnosed cancer in women, and it is also the commonest cancer-related death. The two main modalities of surgical treatment are breast conservative surgery and total mastectomy. Advances in diagnosis and treatment have improved survival rates, where a majority would achieve complete cure. These advances may add years to patients' lives, but not life to years. Therefore, the current trend is to focus on improving health-related quality of life, which is a broad concept involving patients' perspective on impact of illness and effect of therapeutic interventions on quality of life. Most studies evaluating quality of life are from the West, and they have shown poor outcomes. Therefore, we conducted this study to evaluate post-treatment long-term quality of life in women with breast cancer. So we included all women with non-metastatic breast cancer in our study and evaluated their quality of life using validated tools. EORTC QLQC30 questionnaire would assess the general quality of life in cancer patients, and the BR23 module would assess the breast cancer specific quality of life. So this slide summarizes the demographic characteristics of our patients. We included 54 patients who responded in our study, and the mean age was 59 years. And as you can see, most of the women in our study were postmenopausal. The slide shows the types of surgery that our patients underwent. Almost 2/3 of our patients had total mastectomy, and a similar proportion had axillary lymph node dissection compared to sentinel lymph node biopsy. Here's a summary of our findings from the QLQC30 study. And of a total score of 100, most functional parameters assessed shows an average score of 70 to 80%. In comparison to local and global figures, our patients show substantially better health-related quality of life. However, the scores from BR23 breast-specific questionnaire shows contrasting results. The BR23 questionnaire includes 4 function scales, including body image, sexual functioning, sexual enjoyment, future perspective. And it also includes 4 symptom scales assessing the side effects of treatment. As you can see, from a maximum score of 100, most have scores ranging from 16 to 32, which is quite alarming, indicating significantly poor quality of life. Interestingly, these quality of life parameters did not show any association with the type of surgery, probably because our patient's body image doesn't seem to be affecting their quality of life much. We also found that younger women have better quality of life scores compared to older women, and this shows a significant negative correlation. There were several limitations in our study, mainly the smaller sample size and the limited follow-up of around 2 years. Most women in our sample were also postmenopausal. And although we used validated tools, they may also have inherent limitations. So in conclusion, Overall health-related quality of life seems satisfactory. However, most breast-related parameters show deterioration, leading to poor quality of life in these women. And we did not find an association between quality of life parameters and the type of surgery. So based on our findings, we would like to recommend a few things. It is important to give emphasis in improving breast-related symptoms. And sexual functioning can be addressed by referring for counseling. Arm symptoms can be relieved by physiotherapy. Hair loss can be addressed by providing wigs. And it is important to identify these issues early, ideally using trained cancer care nurses, and it is important to address them adequately. So further studies with larger sample sizes are needed to assess the efficacy of these strategies. Thank you.
Thank you, Dr. Jayasinghe. This paper is open for questions. Any questions from the audience? Right. Okay. Since there are no questions, we thank you and we'll move on to the next speaker. The next speaker will be Dr. Sarangan. Okay. And he will be speaking on improving quality of operation note writing through educational sessions and introduction of pro forma and checklist, a quality improvement project. Dr. Sarangan, over to you. Is Dr. Sarangan here?
Yes. Hello.
Yes.
Yeah. Can you hear me?
Yeah, we can hear you. Can you please share your screen?
Yes. Right. So can you hear me? And right. Hello. Yeah. Good morning, everyone. Good morning. I'm Sarangan, currently working as a trust doctor at St. Richard Hospital, Chichester. And this is a presentation. This is actually a first part of quality improvement project. This was done as an audit when I was working at Teaching Hospital Karapitiya. So the audit was done between 1st of January 2023 to 31st of January 2020, and really it was done in 1st of June 2022, 31st of June 2020, under the consultant Dr. Nalita Vijayasundara, along with my colleagues. I would like to start the presentation by telling one of the scientists' great words. If you always do what you always did, you will always get what you have always got. With that, so the background is proper documentation is vital in medical practice, especially in surgery, for follow-up reasons, legal point of view, and research audit. So as a team who always wanted to improve our patient care, we wanted to work on our surgery note writing. So our aim was to assess where our unit stands against standards and to improve the quality of surgery note writing. So these were the objectives: to find out where we stand, determine the possible causes, draft an action plan, interventions, and re-audit. So the criteria were taken from Royal College of Surgeons Good Surgical Practice Guide 2009. There were 22 criteria, and out of that, 5 were optional for obvious reasons such as assistant, and others were mandatory. We took the compliance as 100% as a standard, and for convenience, however, we divided that into full compliance, which is more than 90, partial compliance 89 to 80, and minimal compliance less than 79. This is the document we took as a standard, and methodology we included the patients who came for major, intermediate, minor routine surgeries to our ward, that is basically ward 4 and 7, and we had to exclude minor procedures such as cleaning and dressing. So this is the methodology we used. We traced the BHCs from the record room retrospectively after getting permission. An experienced doctor reads through the surgery note individually, data are entered into number application in iPad, and if the criteria fulfill, yes; not fulfill, no; no applicable, it's taken as not applicable. And This is how we measured the compliance. Basically, number of yes into 100 by total when it is an essential criteria, whereas if it is an optional criteria, and additionally, the total number will include non-applicable as well. So this is the results we could see. The number of documents that were assessed were 56, and as you can see on the board, seven were with a green area, which is a good compliance. Most of the others were very poor compliance, with 4 categories that never existed. There is 0. So these are the areas we thought as good practice. In spite of written by hand, all of them were clear enough to read and understand. Name of the surgeon assistant were mentioned in 54 out of 56 and 37 out of 30 respectively. 54 out of 56 operation note had correct name of procedure. All surgery note noted to have date of surgery. All the surgery note included usage of prosthesis and its type where it has been used. 55 surgery notes out of 56 included adequate postoperative care instruction. This is the place we identified as need for improvement. None of the surgery note had details of type of surgery, name of the anesthetist, serial number of the used prosthesis, amount of intraoperative blood loss, and detailed preoperative antibiotic prophylaxis even when applicable. Only 5 out of 56 notes mentioned the time of surgery. Only just about a third of operation notes included details of incision used in surgeries. 17 out of 56 operation did not feature indications for surgery. Intraoperative surgical findings were not included in 34 of 56 operations. Just 2 operations not out of 56 found to have complication recorded. Extra procedures were mentioned only in 4. 50 not recorded details of tissue removed, added, altered during the surgery. Intraoperative DVT prophylaxis was mentioned only in 1 out of 6 surgeries that were deemed necessary. Only 2 out of 56 surgery were signed by the operative note writer. So these were the recommendation we made, arranging a unit clinical meeting and a discussion regarding surgical and legal importance of accurate surgical note writing, introducing a pro forma and a checklist for accurate surgical note writing, providing the doctors involved in the surgical note writing with above hard copies, and re-auditing it. This is the main intervention we did. We made a formal meeting and we educated our junior doctors. Unfortunately, in our practice, most of the time is written by junior doctors. So this is the pro forma and checklist we made. And really it was done as I mentioned earlier. And this is the results we got. So the results over the board increased or improved only the exception of first 2 categories where they stayed the same. And we managed to improve 1 category from poor compliance to good compliance, and in 5 categories we improved from poor compliance to intermediate compliance. So this is the improvement we made. The following categories had improved from minimal compliance to partial compliance following interventions. Details of surgical incision. Hello?
Yeah, go on, please. We can hear you.
Sorry. Details of sorry.
Go on, please. We can hear you.
Yeah, sorry about that. So details of surgical incision, indication for surgery, intraoperative findings, details of antibiotic prophylaxis, details of DVT prophylaxis. The following were non-existent before, which we could make to existence: writing type of surgery, including name of anesthetist in the operation note, writing serial number of the prosthesis used, including blood loss during the surgery, mentioning details regarding antibiotic prophylaxis. So still we need to improve certain things. Only a quarter of surgery notes were found to be signed by the writer. Merely 16% of surgeries that had used prosthesis had serial number. Only 40% surgery notes had mention about intraoperative complication. Even though writing time of surgery, type of surgery, name of anesthetist involved, extra procedures carried out during surgery, utilized closure time, and intraoperative blood loss were recorded just up to about 50%. So this is the recommendation for next PDSA cycle. Enabling surgical units to produce electronic surgery notes by providing relevant software and hardware. Workshop for internal medical officers regarding documentation. Incorporating medical documentation in medical students' curriculum. introducing 80 memo to remember components of surgery notes, providing support materials to reinforce importance of correct surgery note writing, encouraging operating surgeon to write the operation note himself or herself, which is difficult, spreading the suggested intervention to emergency surgery list and re-auditing it. We found some limitation in our study. So there were reasons for omissions. So for example, information having already been presented in patient's notes, not recording negative factors. For example, if no antibiotic were given, usually they don't write as no antibiotic. This is the way forward. So for the next PDA cycle, we wanted to do wall hanging at a theater and education sessions with senior surgeons to encourage them to write up operative notes by the operating surgeon themselves. And also we want to spread this into the routine surgery and emergency surgery as well, and to the other surgical units. Thank you so much. Thank you for giving the opportunity to present in this virtual meeting. Thank you.
Thank you, Dr. Sarangan. We have one question.
Yes.
The question is, would it be good also to tell the doctor who would have to write
Yeah, she would have to do the writing forms
pre-op
notes.
Sorry, I didn't quite get the question. Sorry.
Yeah, she's trying to ask whether it would be good to tell the doctor to have to do the writing of the forms pre-operative also, not only post-operative.
Yes. Yeah, that's a good point. Yes. Thank you for the suggestion. Yes. We'll do that. Yeah.
And Dr. Sarangan, I have a question now. After the first audit, you introduced a proforma. So in this proforma, was there space for writing complications, extra procedures, etc.?
Yes.
Still, people have not documented anything under those headings.
No, the problem is, we don't have a printed form. So what we do is we gave a hard copy to the house officers, so that they have to, after going through each section, they have to write it. So I wanted to give a printed one, but unfortunately, we didn't have a source. Yeah,
because it's practically not possible. If there was no extra procedure done during a routine operation, probably nobody would write saying that the extra procedures were not undertaken. Whereas it is much easier if you have a printed form, they can just put a cross or a tick across that. So therefore, whether the extra procedures are not done or performed. Same for complications, because routinely we would be writing that there were no complications unless there was a complication. So
that's correct. Yes.
That would be something like introducing a proforma. A printed proforma is something that, if possible, that you can do to improve compliance, especially with these minor topics.
Yes, exactly. That's correct. Yeah.
Otherwise, I think it's a very useful and important area that we need to look at, because generally what we find is operative noting writing is a poor area that we need to work a lot on. So thank you very much for doing this study. Are there any more questions from the audience? Okay. In the absence of further questions, thank you, Dr. Sarangan. Now we are going to go back to the first presentation, which you couldn't do at the beginning. It is to be done by Dr. Mahesh Kamkanamge on the safety and feasibility of intrathecal stem cell therapy for spinal cord injuries, a retrospective study.
Good morning. Spinal cord injury is a major cause leading to lifelong disability. In recent years, intrathecal stem cell therapy is emerging as a therapeutic strategy which promotes improvement of neurological disabilities of patients with spinal cord injuries. It is generally well tolerated, but in our literature survey, we found few case reports of serious side effects like encephalomyelitis. Intrathecal stem cell therapy is being practiced in Department of Neurosurgery, Teaching Hospital Karapiti since 2013. Here we use bone marrow derived stem cells which are extracted from peripheral blood, which was done by Department of Hematology using apheresis following bone marrow induction with filgrastim for several days before the procedure. The procedure is combined with a spinal decompressive surgical procedure like laminectomy, during which the stem cells are injected into the intrathecal space. The aim of our study is to assess the safety and the feasibility of this stem cell therapy in our practice. It was a retrospective study which involved analysis of clinical records of 64 patients who underwent stem cell therapy from 2014 to 2018. Our analysis mainly focused on effectiveness in the filgrastim therapy in relation to stem cell extraction and complications related to field stem therapy and stem cell therapy extraction procedure, and also on complications following the stem cell therapy procedure. The majority of patients were male, age range from 20 to 58 with median age of 32 years. Spinal cord trauma following fall from height being the commonest cause, road traffic accident being the second commonest. Lower thoracic and lumbar vertebral levels were the most commonly affected. Average duration of field stem therapy was 5 days, and the target white blood cell count for effective stem cell extraction, that's WBC count more than 40,000, was achieved in 49 patients. However, sufficient volume of stem cells were extracted in all patients we studied. The majority of patients didn't have any side effects. Only 6 patients had mild complaints that include headache, fever, abdominal pain, chills with rigors, which settled spontaneously. No serious side effects like anaphylactic reactions following field stem administration was observed. In our analysis of complications following surgical procedure that involved implantation of stem cells into the intrathecal space, the most common complication is the surgical site pain, which is actually related to the surgical procedure itself, that occurred in 33 patients. Except 2 patients who needed opioid analgesics, all other patients responded well for simple analgesics like paracetamol and non-steroid anti-inflammatory drugs. Other complications we observed are post-operative fever, which occurred in 31 patients, which is generally a mild fever, settled by 3rd post-operative day. Mild headache occurred in 8 patients, again settled by 3rd post-operative day. We also observed a transient deterioration of neurological functions of limbs in 7 patients, which again improved by the time of discharge. And neck stiffness occurred in 2 patients, and CSF leakage occurred in 1 patient. However, we didn't observe any serious side effects like acute encephalomyelitis. So, in conclusion, bone marrow induction and extraction of stem cells from peripheral blood is effective, and this procedure is well tolerated without any serious side effects. And the procedure of intrathecal stem cell implantation is also tolerated well by most patients without any serious side effects. The absence of any serious side effects encourage further utilization and developments of stem cell therapy for patients with spinal cord injuries, and it's also encourage further studies for assessment of long-term neurological improvement. These are our references. Thank you.
Thank you, Dr. Kampange. Now the paper is open for questions. Sorry, this is recorded present, so we have no time for questions. Thank you. So that brings us to the end of free paper session number 4, where we like to thank all the presenters for completing their presentations on time and all the viewers for their questions. Thank you very much.
Good afternoon. Welcome all back to the Surgical Congress. So now we are moving on with the SAARC pre-paper presentation. And I would like to introduce my 2 chairpersons. That would be Dr. Jayendra Fernando as well as Dr. Risni Kasip. Over to you, sir.
Thank you. I'm Dr. Jayendra Fernando, and my colleague here, Dr. Risni Kasip, is seated. We would like to start with the SAARC paper number 4, evaluation of nebulized N-acetylcysteine in outcome of esophageal atresia with tracheoesophageal fistula, presented by Dr. Anand Pandey. Dr. Pandey, good afternoon. Can you just tell us from where you are speaking?
So right now I am speaking from my department in King George Medical University, Lucknow, India.
Very nice. Just go ahead.
Okay. Thanks a lot. Is it clear, sir?
Very clear. Very clear. Very nice. Just go ahead.
Good afternoon, everyone. This is the title, Evaluation of Nebulized Anastomosis System in Patients of Esophageal Atresia. Esophageal atresia with or without tracheousal fistula is a common congenital anomaly of the esophagus treated by the pediatric surgeons. These patients, because of the late presentation in our setup, may have pneumonitis when they present to our department. This could be the pathophysiology, reflux of gastric contents from the fistula, and aspiration from blown upper esophageal pouch into the lung. This leads to presence thick viscous secretions, which lead to pneumonitis, and ultimately, it may lead to poor prognosis. In neonates, the airway cartilage is more compliant, which leads to closure of airways at relatively lower pressure. Small changes because of this compliance leads to disproportionate changes in the airway flow, and factors such as presence of secretions in these neonates may have an effect on survival of these patients. N-acetylcysteine is a sulfhydryl containing compound. It also acts as a mucolytic agent because of the sulfhydryl containing agent factor, and it has also activity against biofilm because of its antibacterial properties. From that pathophysiology, we can see N-acetylcysteine acts on the thick viscous secretions. Thus, with this background, we attempted to evaluate the role of N-acetylcysteine in liquefying the airway secretions in these neonates and to assess if the nebulized N-acetylcysteine improves the outcome of these patients. It was a non-randomized interventional study conducted in the department from January 2018 to 2019, June to next year. We followed consort guidelines as amended by Reeves and Goss, which has been endorsed by the Equator Network for conducting this study. Patients with diagnosis of esophageal atresia and tracheousal fistula were admitted. Patients of pure esophageal atresia or evidence of sepsis were excluded. In written, informed consent were obtained from either parents or attendants. The patient were allocated into two groups. One was study group, group 1, other was control group. The study group received nebulized N-acetylcysteine. Control group received nebulized saline. Data was analyzed for age of presentation, sex, consistency of secretions, duration of discharge, and mortality. Data was analyzed using SPSS version 16.0 for Windows. This was the flowchart of material method. Group 1 received nebulized N-acetylcysteine. Group 2 with saline. Collections were made from upper esophageal pouch secretions and they were analyzed on a handheld calcistometer. This is a design which has been designed by us and has been submitted for grant of patent to the Indian Patent Commission. This is the raw design line diagram. Secretions anywhere taken from the upper esophageal pouch were dropped at 0.0 and time taken to travel a specific distance, say 5 centimeters, was calculated in seconds. Thick secretions take more time to travel as compared to thick secretions. These all are leveling screws, split level, tilted scale at around 20-degree angle, which can be changed. During the study period, there were 73 patients which were assessed for eligibility. 7 were excluded. 66 patients were allocated to two groups of 33 each. In group 1, 3 patients left again medical advice. In group 2, 2 patients were transferred to pediatrics and 1 left again medical advice. Hence, final analysis include 30 patients in each group. In results, there were 30 patients in each group, which were both age as well as sex matched. On comparing the consistency of secretion between the two groups, there was no specific change on day 1 and 2. But from day 3 onwards, the secretions decreased gradually in consistency in amount in group 1 as compared to group 2 to the extent that minimal to no secretion were achieved in group 1. This was statistically significant. We also compared the neonates on basis of presentation within 2 days of life and after 2 days of life, and consistency was significantly thin in those patients who presented within 2 days as compared to those who presented after 2 days of life. Mortality was higher in group 2. However, this was not statistically significant. On comparing the day of discharge between the group, the discharge time was significantly less in group 1 as compared to group 2. The Kaplan-Meier survival curve did not show significant difference between the groups. The strength of study. This is the first study which has analyzed role of N-acetylcysteine in neonates of esophageal atresia with tracheostomy fistula, and most importantly, We objectively analyzed the secretions, their consistency on the basis of the handheld consistometer. Limitations. There were confounding factors such as congenital heart disease, which could not be eliminated. However, we believe since both groups were matched, this was having less effect, but still it can be regarded as limitation. And sample size. Mortality could have been statistically significant if we had a more sample size, but this was not possible during the study time. In conclusion, nebulous anesthetic 16 decreases the consistency of secretions in patients of esophageal atresia with tracheostomy fistula. It helps in early discharge of patients. It may also be having an effect on the survival. However, further prospective studies are needed, especially double-blind randomized controlled trials. The study received funding from Intermural Grant, Research Cell, King George Medical University. Ethical clearance was obtained for the study. We have no disclosure to make, and there is no conflict of interest. I thank all of you for patient hearing. Thanks.
Thank you, Dr. Pandey. That was a very interesting study. I just want to ask you one clarification. How did you allocate your patients into the two groups?
Sir, it was a non-randomized intervention. We did not randomly divide. Initially, we were not sure as to how many patients we will be receiving during the specified time period. So we didn't go for a randomized control trial.
Oh, thank you. Krishni, you have any questions?
What is the normal survival of these patients, these children?
So normally, as per the literature, it is close to 70%, 60 to 70%.
60 to 70%. And what type of survival increase do you expect from this intervention?
So they survive, but they may have complications such as esophageal stricture. They may present in later life, hoarseness of voice, feeding problems. Even studies have shown that there are some growth abnormalities in the patients of esophageal atresia.
Yeah, there are no other questions that have come to us. Would you like to say anything before we wind up? We have a couple of minutes if you want to make any comments.
So we very meticulously conducted this study, and I guess this will be beneficial if other pediatric surgeons also use this modality in the treatment of these patients. Because in this SAARC area and in developing countries, no neonate presents within day 1 or 2 of life, which is the most crucial period.
Okay, Dr. Pandey, thank you very much for presenting your paper.
Thank you.
All the very best to you.
Thanks.
Thank you very much.
We'll go to 7 now. Yeah, go to 7.
Number 6. 4, 6, 7, number 6.
Right, we can go to 6.
So you stop this. Now the next presenter is Dr. Zian Lun Lo. The topic is improvement of quality of life with treatment of chronic venous disorders with disorder patients in Kandy in Sri Lanka. Over to you, Dr. Zian.
This is SAARC paper 6.
Good afternoon. I am Lo Zhen Luan, a Year 4 medical student at Duke NUS Medical School in Singapore. Today, I will be presenting on my project titled Improvement in Quality of Life with Treatment of
Dr.
Chronic
Luan,
Venous
from where are
Disease
you
in Sri
speaking
Lanka.
currently?
Chronic venous disease is a common chronic disease of the venous system of the legs, affecting patients' well-being. The Vein Consult program involving 23 countries over 4 years showed a worldwide prevalence of 63.7% and 51.9% in Asia. Patients suffer from symptoms such as pain and swelling and complications such as venous ulcer, which limit their ability to ambulate and work. Treatment helps to reduce symptoms and prevent complications which adversely affect quality of life. With approximately 25% of the Sri Lankan population suffering from metabolic syndrome, a high disease burden is expected as obesity is a known risk factor of CVD. However, there is a lack of quality of life studies in Sri Lanka despite the expected high disease burden. Hence, the primary aim of this study was to assess how treatment for CVD would improve quality of life of patients. The secondary aim was to compare the improvement in quality of life across different treatment groups. The final aim was to assess the perceptions and treatment-seeking behaviors of patients. We hypothesized that quality of life improves with treatment. We conducted a prospective observational study of 58 patients recruited from the teaching hospital Peradeniya. Patients were followed up at 4 and 8 weeks after treatment. We had 3 study groups. Firstly, patients who received surgical treatment such as multiple step avulsions, vein ligation, and stripping. Secondly, patients who received non-surgical treatment such as sclerotherapy, endovenous laser ablation, or 4-layer bandaging. Lastly, patients with no treatment. The primary outcome was change in quality of life at 4 and 8 weeks after treatment as measured by the 14-item Chronic Venous Disease Quality of Life Questionnaire, CIVIQ-14 in short. It consists of 3 domains, pain, physical, and psychological, which total up to a global score. Scores range from 0 to 100, with a higher score indicating a better quality of life. Other variables such as social demographics, risk factors, CEAP class, and symptom severity were considered as covariates. We recruited 17 patients with CEAP class C2 and 43 patients with severe CVD of CEAP class C3 to C6. No C0 and C1 patients were recruited. 27 patients received surgery, 23 patients received non-surgical treatment, while 8 patients had no treatment. I discussed the main findings pertaining to our primary aim to assess how treatment will improve quality of life of CVD patients. An increase in global score of at least 5 points is a clinically meaningful improvement. This table shows the CIVIQ-14 global scores by treatment groups. At 8 weeks, there was a significant improvement in global score, which was greatest for the surgical group with adjusted least square mean of 23.5, followed by the non-surgical group of 13.3. There was no significant difference in the improvement in quality of life scores between the surgical and non-surgical groups. No significant improvement in scores for no treatment group was seen. Similar results were seen for pain and physical domains at 8 weeks, and likewise for global and all domain scores at 4 weeks. That is, significant improvement in quality of life scores for surgical and non-surgical groups with no between-group differences, and no significant improvement for the no-treatment group. We found similar results to the RELIEF study, a multi-center international study involving 18 countries including Sri Lanka. CIVIQ-20 global scores improved from 64.1 to 73.1 at 8 weeks post-treatment with micronized purified flavonoid fraction. Randomized controlled trials comparing sclerotherapy, EVLA, and surgery demonstrated significant improvements in quality of life, with no substantial between-group differences. This is similar to results from our study. Our study had limitations. As a single-center study, our results cannot be generalized to other regions of Sri Lanka. Although our study was adequately powered, we had to pool sclerotherapy, EVLA, and supportive treatment into one non-surgical group given their small sample sizes. We did not recruit C0, C1 patients as they tend to be asymptomatic and not seek treatment. In conclusion, chronic venous disease can affect quality of life negatively if left untreated. Our study showed that both surgical and non-surgical treatments improve quality of life significantly from before treatment to 4 and 8 weeks post-treatment, confirming our hypothesis. No significant improvements in the no-treatment group were seen. We also reaffirmed the importance of quality of life as a clinical measure of treatment success. These are my references for this presentation. This is the end of my presentation. Thank you for your attention. I would like to acknowledge my mentors, the co-authors, Teaching Hospital Peradeniya, Ms. Dilani, and SingHealth Duke NUS Global Health Institute.
Thank you, Dr. Jan. Can you hear me? Dr. Jen?
I'm sorry, I was in the pre-discussion room.
No problem. It's a very, congratulations on very good work done here. Now, in the non-interventional group, what were your EVLA and sclerotherapy, all those was grouped 1, was it?
Yes, because we were unable to recruit enough patients to split them into separate groups, as the sample size would become too small for each subgroups. But
Yeah.
overall, our sample was adequately powered to detect changes between treatment versus no treatment groups.
Right. But this number, was it enough to check between subgroups the quality of life improvement? Example, between EVLA versus open?
Yes, so we powered it. We used a similar study that was done in Europe to calculate the sample size with an effect size of 0.4.
Right. So how long do you think this study should have continued to see whether the quality, did you see a plateauing of quality of life, or did it continue to increase with time?
Unfortunately, because our study, we could only follow up for up to 8 weeks. There are other studies that follow up to 3 months and 6 months. There was still significant improvement in quality of life. However, I think that the improvement naturally got less and less as compared to non-surgical as well as surgical group. We were not able to assess for any complications, so we did not check for any disease recurrence. So anytime before 8 weeks, we are unable to comment.
Right. Why do you think there is a increase of quality of life between, I would expect the quality of life to reach a peak by 4 weeks. Why do you think between 4 weeks and 8 weeks following treatment, also they continue to improve the quality of life?
I think this is in particular for surgical group, as within the first 4 weeks, they will be recovering from the surgery. So there might still be some post-op swelling, post-op pain, as well as perhaps inadequate pain control that might result in less improvement in quality of life that will be better seen after 4 weeks post-surgery.
The time's up, Dr. Jain. Thank you very much. It was an excellent presentation.
Thank you very much for Paradenia for this opportunity.
Okay, we move on to the next presentation, which is the SAARC paper number 7, improvement in quality of life among patients with hemorrhoids after invasive treatment in Kandy, Sri Lanka. The paper is presented by Dr. C. Ying Julian Keen.
Yeah, hi, sir.
Yes, from where are you speaking at the moment?
Yeah, so I'm from Singapore, speaking from Sing Health Duke NUS Medical Center.
Okay, you're very clear, so go ahead with your presentation.
Okay. Today, I will be presenting on. Good afternoon, my name is Julianne and I will be presenting on behalf of all the authors today. I will be presenting on improvement in quality of life amongst patients with hemorrhoids after invasive treatment in Kandy, Sri Lanka. Hemorrhoids is a common chronic disease that significantly disrupts patients' daily lives and well-being, where clinical assessment alone may not adequately assess the overall impact of the disease. However, few studies have been conducted to evaluate the health-related quality of life of patients with hemorrhoids pre- and post-treatment, especially in low to middle-income countries. The primary aim of the study was to investigate the health-related quality of life of patients with hemorrhoids before and after invasive treatment. Invasive treatment includes sclerotherapy with 5% phenol, rubber band ligation, hemorrhoidectomy, or the evacuation of hematoma. The study was a prospective observational study of 58 patients with hemorrhoids conducted at 2 public hospitals in Kandy, Sri Lanka. The short health scale, adapted for hemorrhoidal disease, abbreviated to SHSHD, assessed hemorrhoid-specific quality of life. This questionnaire is the first hemorrhoid-specific quality of life tool which was found to be reliable, responsive, and valid as an outcome measure after treatment. It assessed 4 domains: symptom load, interference with daily activities, concerns, and general well-being. The questionnaire was interviewer-administered in Sinhala at 3 time points: during initial consult, at the 4-week follow-up, and at the 8-week follow-up after treatment. For the statistical analysis, the primary outcome variable was the change of health-related quality of life scores from baseline. We performed a repeated measures linear mixed model analysis on the health-related quality of life change from baseline scores, adjusting for baseline health-related quality of life scores. For our results, 48 out of 58 patients received invasive treatment. The focus of our analysis was on this group of patients as few received medical, supportive, or no treatment. As baseline health-related quality of life scores was significantly associated with post-treatment scores and change from baseline scores, it was included as a covariate in the analysis model. Figure 1 on the left shows health-related quality of life mean scores at baseline and the least squares mean scores at week 4 and week 8 follow-ups. A higher SHSHD score reflects poorer quality of life. In Figure 1, post-treatment adjusted least squares mean scores showed significant differences between week 4 and week 8 for the total SHSHD score and across all domains. Figure 2 on the right shows the health-related quality of life change from baseline scores at week 4 and week 8 and difference in change from baseline. Positive values for least squares mean change from baseline indicate improved health-related quality of life. Figure 2 shows significant improvement in health-related quality of life across the total SHSHD score and all domains at week 4 and week 8. Differences in change from baseline were negative, as we took the difference between change from baseline at week 4 and change from baseline at week 8. For graphic representation, differences in change from baseline are shown as positive values. Therefore, Figure 2 also shows that health-related quality of life scores not only improved from baseline to week 4 and week 8, but that they continued to improve from week 4 to week 8. As a secondary analysis, we compared the health-related quality of life of patients post-treatment across the different types of invasive treatments. Our results showed that those who received rubber band ligation had greater improvement in health-related quality of life than those who received sclerotherapy. A large percentage of employed people in Sri Lanka work in the informal sector, consisting mostly of labor-intensive jobs and a dependence on daily salary. As such, hemorrhoids can impact their quality of life and ultimately affect their livelihoods. Evaluating health-related quality of life is imperative in assessing the impact of the disease on patients with the goal of treatment to address their symptoms and improve quality of life. The SHSHD was previously shown to be responsive and highly correlated with symptom load and patient satisfaction postoperatively. Thus, improved health-related quality of life after invasive treatment further emphasizes the benefit of hemorrhoid-specific quality of life as a way to assess treatment outcomes together with clinical findings. Hemorrhoids is also a multi-symptomatic disease where resolution of one symptom may not improve quality of life. Symptoms may also reduce in frequency but still have a severe impact on well-being. With a high patient load and limited resources in low to middle income countries, the SHSHD may be used as a quick and more robust means to monitor disease. Our study also showed patients who received rubber band ligation had greater improvement of health-related quality of life compared to sclerotherapy, similar to that of other studies. However, rubber band ligation is not widely available at all public hospitals in Sri Lanka, and this may have greater implications in the reorganization of medical resources. Limitations of our study include the use of convenient sampling and a small sample size. The SHSHD had not yet been validated in Sinhala in the Sri Lankan population, although the questionnaire was translated by a Sri Lankan healthcare professional and reviewed by a sworn translator. Future studies could cross-validate the SHSHD and further investigate its use in Sinhala in the Sri Lankan population and even in other languages. We would like to acknowledge the following institutions for their support in our study. Thank you for your kind attention.
Thank you, Dr. C. Can I just ask you how the patients were allocated to the 3 forms of treatment?
Yeah, so it wasn't randomized. It was based on the clinical decision of the surgeon, and we just followed the patient. So if the surgeon decided this patient was to get sclerotherapy, then we would take that. We would follow them accordingly. Yeah.
There's another question that has come. Do you have any ideas related to diet changes and straining in the toilet, the time in toilet, etc., apart from the intervention? Other than the surgical intervention, whether any of those other habits played any part in the management?
Yeah, so most of the patients, in addition to getting invasive treatment, received some form of patient education and counseling in terms of their diet, dietary changes in terms of squatting or straightening. However, we weren't able to differentiate if the improvement in quality of life was solely based on dietary changes alone, or if it was due to the invasive treatment, because the patients that decided no treatment or weren't allocated invasive treatment was such a small number. So we weren't able to compare across those groups.
Thank you very much. I think it's a very interesting paper and you have done some good work.
Thank you very much, Dr. C.
Thank you.
Congratulations.
So that basically concludes our SAARC paper session. And thank you very much for joining. Okay, bye.